Dr. Caitlin Regner is a 2019 graduate of the Department of Family Medicine and Community Health in the Madison Residency Program. She currently works at Access Medical Center at the Erdman Clinic. She is the Access Medical Director of Pregnancy and Substance Use Disorder. She has 4 children and a partner, and they live locally, and she enjoys running.
Dr. Sree Atluru graduated from Oregon Health Sciences Center in 2016, finished residency, and started the department in 2017. Thank you. I knew you started the department in 2017. And really from starting at the Department of Family Medicine here in Madison has taken on this role as being a champion for our care of prenatal patients with substance use disorders. And this is a passion of hers. She received lots of excellent training on this type of care during her residency and has shared a lot of her expertise with our residency program and with community faculty as well. And so really grateful to have had the opportunity to work with her both as a resident and now post-residency as well. I have to just give a nod to her because really much of what I've learned about treatment of substance use disorder in pregnancy is related to sort of a apprenticeship that I've had with Dr. Atluru. So with that, I'll let her start talking.
Okay. All right. So we've kind of divided this up into 4 parts and then a question and answer at the end. If there are any questions, please feel free to use the chat. Pertinent disclosures, we have none. Sorry. The next slide is about objectives. And so I think kind of one thing is to highlight reproductive age individuals with substance use disorders. Second thing would be to connect pregnant people that are identified, both pregnant and substance use, that's the topic, to high quality evidence-based care within our department and elsewhere, and then to engage and provide kind of equitable care for people with substance use disorders in pregnancy. I think we have a lot of power that I think that in advocacy for patients and we serve our communities around the state. And so I think it's really important, and around the country and around the world. And so I think it's important to make sure that we understand our own power and our own worth and our own biases. So the next slide is just like a brief language kind of a note on inclusive language and pronouns. And I wanted to include this just because it really has changed my practice over the last, since I've, 7 years or so since I started residency, and stigmatizing language that can trigger some people. And I really, I always ask patients, I kind of mimic what they say. Like a lot of patients do use the words clean versus dirty urine and sober. And I think it's really interesting that they use that because there's a lot of shame associated with those words, and especially shame when we as providers and medical providers use that language with patients. And I try to help people understand, like, use person first language. So, person who uses heroin, person who uses oxycodone, rather than an addict or polysubstance abuse, because that's not a DSM-5 diagnosis anymore, and it's not billable, and it really implies a level of shame and a level of judgment that's not intentional. But it's really important to be mindful of the language that we use. And so I thought this was really a nice slide, and I show it at a lot of the talks, and Caitlin does too. Just to kind of like say, like, how do our words matter a lot, and how do we use our words to empower people rather than disempower them? And the perinatal harm reduction kit, if anybody's interested, it's at the end of our presentation, but it's a great document for just inclusive language, inclusive pronouns, asking people how they want to be addressed, what pronouns they prefer that we use. There's a way in Epic to actually highlight that as well. And that's just been really important for me, just because we all we do not want to intentionally harm a patient or cause more psychological trauma, but the words that we use in the medical document and in our daily lexicon can be very, very stigmatizing for people. So I thought this was important. And I think also just highlighting, like Caitlin and I were chatting earlier, just like we treat diabetes as a medical disease, and addiction and opioid use disorder is a medical disease. And so, you know, we tell people who have, you know, substance use disorder, oh, like, you know, why can't you just stop? That's what a lot of people have asked in the medical field, outside the medical field. And it's like asking a diabetic, you know, well, if you're not going to take your meds, then why should I help? You know, why should I continue prescribing them? Or, you know, I have a patient who had an MI like 3 years ago, very young, doesn't take any of his cardiac meds, but they didn't refuse him getting a stent. You know, they stented him maybe 3-4 months ago. But that's not held over people, whereas sometimes we hold this over people.
I have a little
Yes.
I have a little checking our bias activity for us to go through in just a second. So about that.
Yes. So, and then the other background is like, you know, like I think the word narcotic is a legal and police term. It's actually not used in much of the addiction world, and Allison Miller is on the call and can highlight that as well. But opiates are natural opioids, so heroin, morphine, codeine. So when you type opiates, it actually implies those three things in the documentation. And then opioids are kind of the overarching category. And so I encourage people to kind of use the preferred term of opioid to avoid confusion. Also, narcotic can have a lot of visceral connotations for some folks, because it refers to any illicit drug. It has like DEA references. And so typically to make a more medical term would be to use the word opioid rather than narcotic. Caitlin, you can go to the next slide and then kind of like, and I just a little bit more in background, and I don't want to take up too much time, but I think it is important. So untreated opioid use disorder in pregnancy is associated with preterm labor, specifically before 36 weeks. It's associated with fetal growth restriction. It's associated with neonatal opioid withdrawal syndrome. We're not going to talk about that, but that's a subsection of neonatal abstinence syndrome. They are two different things. And there are also higher rates of infant death within the first year of life. It's not a direct correlation, but it's enough that the state of Wisconsin and SAMHSA, which is our governing body nationally, have highlighted it. And I think this slide is pretty telling about, you know, maternal opioid use has increased. I do think it's also a little bit biased in that it doesn't separate out opioids that people have injected versus oral opioids versus medication to support people. And so I think that's also another thing that can be problematic about this slide, but it just shows the point that there are more people using opioids and there are more infants born to parents who use opioids.
And so just briefly, I want to make sure that I give appropriate credit here. So this, we in Access recently had a talk with the addiction medicine fellows. So Elizabeth Salisbury Apskar and I'm forgetting the other person's name. But so this actually comes from them, so I want to give them due credit. But I just think this was a really helpful process to go through to think about how we, just like you were saying, Dr. Atluru, how we think about the way that we interact with patients who have opioid use disorder. So you see a 54-year-old female in your office with type 2 diabetes. Her recent A1C was 12. When you do chart review, you see she frequently misses appointments with the nurse, with the dietitian. She's gaining weight despite multiple referrals. And she is taking her cholesterol medication. So when you see her, what's your response? Do you tell her that unless she follows your recommendations, you're going to have to discharge her from your care? Do you understand that her diabetes is never going to be controlled and decide to continue to be her provider, but just focus on other health issues? Or do you try to explore barriers, celebrate her cholesterol control, and see what her goals of care might be? So this is like sort of ridiculous. Obviously, we all know how we're going to manage somebody with diabetes, but I do think it's helpful to share because sometimes our line of thought doesn't go straight to that that same focus when we're talking about someone with opioid use disorder. So let's just say it's the same woman, 54-year-old female. Obviously, this is not a person of reproductive age, but coming in for severe opioid use disorder and buprenorphine. This person has urine tox screens that are positive for cocaine and buprenorphine and occasionally for benzodiazepines. They've been negative for other opioids. Sometimes she no-shows your appointments and she's not always seeing the therapist that you've recommended. What would you do? So again, it's kind of the same tier here. Are you going to tell her that unless she follows your recommendations, you're going to discharge her from her practice, understand she'll never achieve recovery and just stop talking about the opioids and focus on other health issues, or try to explore barriers, celebrate negative opioids, and then look into her goals of care? And so I think that in thinking through, how we manage patients with diabetes, how we manage patients with, as you mentioned, Dr. Atluru, cardiac complications, a variety of other issues, which there are certainly patient factors and patient habits and things that play into those diseases, just as in opioid use disorders and other substance use disorders. I think we need to check ourselves and ensure that we're going into these encounters really trying to understand patients, where they're coming from, and their goals. And I would just add that, as we're thinking through pregnancy and how people manage pregnancy, I think it's important for us to check ourselves when we are seeing patients for the first time who are either considering pregnancy, so whether we're in this preconception counseling type of a visit, or whether we're seeing a patient who's already pregnant. I think we need to be neutral as far as our language about, how are you feeling about being pregnant? And what are your thoughts about this pregnancy? What concerns do you have? What questions do you have? And really let the patient guide the conversation. I think we need to be careful not to assume that any person who is, working and financially well off and in a stable relationship, we don't want to automatically assume that that person desires pregnancy. Similarly, we don't want to assume that someone who's not in a stable relationship, who doesn't have a job and who's using opioid disorder, or who's using opioids or other substances, automatically would not want a pregnancy. So really allowing patients to guide our conversations with them and being open to helping them in whatever way they need. So this next section is about screening. And so first, we're going to talk just a little bit about how we screen for substance use disorders. And then in addition to that, screening tests that are done in light of substance use disorders. So there are several different tools that are used in primary care to screen for substance use disorders. One is SBIRT, which is something that I know Access, and I know more about our policies and procedures than I know about the entire Department of Family Medicine. So, you can think through at your individual clinics what you're doing, and this might be a point of conversation at your next meetings about how are we doing substance use screening and what could we be doing differently potentially to capture more use disorders. But certainly at Access, we are doing this SBIRT screening for patients, non-pregnant and pregnant patients. And then we've recently incorporated the 5 Ps, and so that's a specific to pregnancy screening. And I'll skip ahead just so we can take a look at that. So this is the 5 Ps method. This is what's being used in UW OBGYN to identify potential issues surrounding substance use. So did your parents have a problem? Do your peers have a problem? Does your partner have any issues with drug or alcohol? And then assessing what people's use was before knowing that they were pregnant, and then current use. And then, of course, making sure that tobacco use is playing a role in that as well. Within our clinics, most of these initial screening questions are being done by prenatal nurses at the pregnancy intake visits. But there are going to be situations, I've certainly had them, and I'm sure many of you have had them as well, where a patient comes in and is nauseous and hasn't had a period for a while, and you incidentally find out they're pregnant. And so this might be part of that initial conversation, in particular if you know that substance use has been an issue in the problem, problem in the past, you're going to want to make sure that you talk about that. Going back to the other blood testing that's done. So there's prenatal testing that's recommended for all pregnant patients, but with for people who have a history or are currently using substances, it's recommended to add on additional screening labs. So here now hepatitis C screening is actually recommended for all pregnant patients. That didn't always used to be the case. But you could consider screening more frequently for higher risk patients for hepatitis B, C, HIV, and other infectious diseases. And then urine drug screening, I really try to, when I talk about these screening tests in general, I try to make it be about safety and about protocols to normalize what we're doing so that patients don't feel singled out. Sometimes even just talking about we're going to need to collect a urine, that can, similar to NARCs, that can have a triggering effect. So just mentioning that for all patients at the start of their, pregnancy, when substance use has been an issue in the past, we collect, a urine sample, and even just stating outright that, the urine drug screen or whatever test that we order are always going to be informative to help guide conversations, but they're not black and white. They don't, one result doesn't mean that someone's going to be discharged from our care. So even just providing some of that reassurance, I think can be helpful. And like I said, normalizing the process. This is a quick screen. So if you're seeing somebody and maybe don't have that full time for the intake visit, an easy way to just talk through and make sure you're tackling all of the major topics for use disorders. So alcohol, tobacco, prescription drugs, and illegal drugs. So this is the committee opinion from 2017, ACOG, early universal screening, brief interventions, and referral for treatment improve both maternal and neonatal outcomes. I think that's one of those things that seems like a no-brainer, but it's good to be aware of and to recognize that that brief amount of time that you're taking doing those screening questions matters, and that time that you put in earlier on in the pregnancy has major payoffs at the end. And then opioid agonist pharmacotherapy is the recommended treatment for women who have opioid use disorder, specifically in pregnancy. So I think this is an interesting fact to just highlight the way that buprenorphine wavering plays into not only our identity as a specialty, but also I think puts us in a position to be able to care particularly well for these patients. Many of us, especially those who have their waiver, are very comfortable talking to non-pregnant patients about their use disorders and have experience in managing buprenorphine and in referring to counseling, and have probably had to work through issues of relapse and perhaps building up trust in this and working through social issues and psychiatric conditions that tend to go along with use disorders. And so I think that we are in a position that's well poised to be able to provide excellent quality comprehensive care for pregnant people who also use substances, because we're already doing it for people who are not pregnant.
Thank you, Dr. Regner. So I just kind of wanted, this is just briefly about prenatal care, and I wanted to work through a case, and it's hard when it's video and everything else. But anyways, sorry about that, Caitlin. So this person identifies as female. We asked her already. So we have asked pronouns at the beginning. So you're with a patient, you're in a busy afternoon, like my afternoon and Caitlin and Bill's and everybody's, and it's a well child check, and comes in, and you see the other parent as well, and she goes, I haven't, like, hey, you're just chatting about the baby, and then she's like, oh, by the way, I haven't had a period since I had my baby 9 months ago. Is that normal? And she asked, and she asked for a pregnancy test. So You have her quickly run out, do the pregnancy test, come back in. You're still doing the well child visit because that's always how it works in family medicine. And you get a knock on the door, and somebody hands you the result. In clinic, it usually pops up on the computer, so I just leave the patient's chart up next to their child's. And it's positive. And so you kind of sit down, you kind of look at her, the baby's wailing at this point and just is wailing. So you like take the baby and like try to console the baby as you're trying to have this conversation. And it's positive. And you say, hey, your pregnancy test is positive. You know, how do you respond? What do you do? And you know, she wasn't planning on getting pregnant this soon. She said maybe another year, or she didn't know. She wasn't using any birth control. And so you know, you remember that you got this Care Everywhere message that she went to the ER maybe 2-3 weeks ago because she overdosed and they had to give her naloxone. And so you're like, hey, like, tell me a little bit about more, like, what's going on in your life right now? And she like feels comfortable with you, and she's like, I'm actually injecting heroin every day. And I need to do that to get through my day. And it's really hard for her to admit that. Like, what do you do with that? I mean, that now it's 2 o'clock in the afternoon. It's not the end of your afternoon. So, you know, it's gonna, in the back of your mind, it's going to totally blow your day. But what do you do? And so I'd like to think about that as we work through it. And everybody can do it differently. There's not a right way to do this. But, you know, like, consider the NIDA, like consider the positive screening, and we'll kind of go to the next slide and kind of like, I'll just kind of talk out loud because, you know, this would have been like a question and answer thing. And if people have questions in the chat, they can put stuff. But Caitlin, you want to go to the next slide? Sorry. And so you know, like Caitlin mentioned, so the academic section of obstetrics and gynecology here at UW is doing universal screenings for all of their prenatal patients. Typically, it's actually done at the provider visit rather than the nurse visit because they found that when they did that initially, the providers were not looking at the nurse visit. And so it's something that, you know, I think is interesting and our department is discussing as well. I kind of like, so the baby's calmed down now, the baby's sleeping on you, and you know, baby, it's very cute. We all like snuggling babies because we can give them back. I ask people, like Caitlin said, Dr. Regner said, how do you feel about a positive pregnancy test? Like, how are you doing with that? And, you know, patients have a variety. They're like, some patients are like, I'm super happy, I'm so excited. Some patients are like, I really don't know how to respond, I don't know what to do. And it's a hard conversation. And I think what I always ask people is like, how do you feel about a positive pregnancy test? I don't say, how do you feel about being pregnant? But I just say, how do you feel about a positive test? And have you thought about what you'd want to do if this was a positive pregnancy test and there was a pregnancy or is a pregnancy? And like Dr. Regner was saying, I think ensuring that we give patients the autonomy and control about, like, sometimes pregnancy for some people is life transforming. And sometimes it's not what they want, and they have options in the state of Wisconsin for that. It's just, if a patient wants to terminate, then they need to be referred pretty quickly because we do have limitations to that. But ensuring that we do a good job of like non-biased options counseling. There's an order set in Epic that is called, and I'm pulling it up right now. The ones of us that do OB care, I think we kind of have it as part of our smart sets, but I think it's helpful to have. It's the OB initial visit smart set. And they're changing it to include hepatitis C. And so there's a lab panel that you can order. You can order the hepatitis C. If you feel like a quantitative HCG is indicated, you can get one. If you're, you know, and then Caitlin talks about urine drug screen. I think the thing is, like, if your patient's forthcoming about it, I don't usually do it. I'm a little bit I'm kind of getting away from urine drug screens. They're $600. They're really expensive. We don't have point of care at UW at all, even within access. And it takes a week to come back. And how is that going to change my judgment about what they want to do? I don't know. And I have a drug screen from 2 weeks ago, and they've openly admitted. But I usually ask patients and give their verbal consent and document it in the chart and say, here are the things I'm ordering. I turn the computer to them. Here are the things I'm ordering. May we order this testing? And you have to do that by law for the hepatitis HIV at least, by state law. But I also verbally discuss, like, can we just make sure you're being safe and make sure your heroin's not getting laced with fentanyl, because that's happening everywhere in Wisconsin right now. And that's really dangerous. And that can, especially in pregnancy, people die, and you have a 9-month-old. I just want to make sure you're safe and you know who you're getting your heroin from, because a lot of people are like, there's no fentanyl. I know there's not fentanyl. And then it ends up being fentanyl, and they're really shocked by that. Refer or arrange for an outpatient dating ultrasound. So there are, and I want to highlight like what the other community and residency clinics are doing. So in my practice, I don't do dating ultrasounds. I know how to do them, but it's not part of my daily practice anymore. But the residency clinics and access do have dating ultrasounds. And so we at DeForest, Windsor, have arranged for all of our dating ultrasounds to actually be done at Northeast. Which is one of the residency clinics, number one, to help support the residency program and training and education. And number two, our patients don't want to, and Bill, I'm looking at you, patients that live far away from Madison don't want to drive to Madison. And so we have made this arrangement, and I hope that other folks in the community clinics may seek that out. Belleville's a close clinic to some of the folks on the southern side of Dane County. Verona, I think, and Maggie can correct me if I'm wrong, does dating ultrasounds, or Anne, and then Access, Wingra. But we send most, if not all, of our dating ultrasounds to Northeast. And that's just now become our standard protocol. And so I think, and then OB can do that as well. And then you can always contact us. I am very available by phone. The OBs contact me pretty regularly. I usually get a once a week phone call from somebody. And then, and Caitlin can assist with that. So what I've done typically is if I get the phone call, patient doesn't have a primary, Caitlin has a great program at Access, and so she has a lot of behavioral health support, and so I usually send patients to her. Allison and I have partnered together on one of her patients. I don't take the patient. I don't steal patients from people, nor their babies. I make it very clear at the first visit that I just will do their prenatal care, and they go back to you. But that's been arranged. And so it's been really exciting to see that flexibility and just kind of supporting the training and learning in our department for all of us. And then I always make sure, even if they're not on opioids, like let's say they're using meth or something else, meth is really popular, cocaine is back in a very bad way, and benzos. And so I always, naloxone only works obviously for opioids, but I always prescribe a naloxone spray for these individuals. There's a 2-minute YouTube video. You can learn how to do it. It does save people's lives. And I just give it to everybody now, even if people that are on chronic opioid therapy or methadone therapy or for pain, I give it even if their morphine equivalents are pretty low, because you just never know what's going to happen. You don't know if their grandkids are going to get into it. It's very inexpensive, and Medicaid does pay for it now. There are also vouchers and other programs throughout Dane County, Rock, Columbia, and Jefferson that help pay for it if there's a cost issue. Otherwise, like the central pharmacy is a great resource, and you can always, if a patient can't afford it, there's the medication assistance program at UW, and they're great. And look into your own programs as well. So we can go to the next slide. Prenatal resources. So I and Dr. Howlett, shout out Dr. Howlett, who really has helped me a lot, in addition to Dr. Regner and Dr. Dreesang. I work particularly with ARC. I don't know what ARC stands for. I've asked them. It's a ARC program is specifically for people that identify as women and their children. It's in Madison, and they take outside referrals. The ARC Maternal and Infant program is an 11-bed program that has a treatment house here in Madison. They take referrals from around the state, and county-based referrals. And if you need assistance on that, it's actually the social workers at any UW or clinic or SSM clinic know what ARC is and know how to get in touch with their county-based provider to help pay for this program. Otherwise, it's a Department of Corrections referral, and it's a 6-month program. ARC also has other locations. They have one on Dayton Street for women. They have, and then they have outpatient treatment at Emil Street, and it's really an amazing program. And you know, Safe Communities, Madison-Dane County is also an amazing program. And they are an organization primarily based in Dane County, but they have contacts throughout the state. And so if you have patients residing outside of Dane County, I still call them. They have a great resource that's called Pregnancy to Recovery. And so they have peer support specialists. And I tell all patients this, like, I feel like in terms of like addiction management and substance use, I do like maybe like 5% of it. The rest is like is their peer support. So a peer support person, and most of the peer supports in pregnancy are doulas. They're double trained. These are people that have been through what those women have gone through. And they may be in a different point in their recovery. And so they have specialized training in being a peer support, which is different than NA and different than AA. And they work on helping people create goals. Most of them have used while they were pregnant. Some of them aren't all of our patients, and some of them have delivered with you. These are amazing resources, and Tanya Craigie is the one who runs the program. If you have any issues she and I chat like weekly. If you have any issues getting a hold of her, let me know, or let Caitlin know, but Dr. Regner, but literally this is the thing that makes the biggest difference in people's lives. They also have peer recovery coaches and peer support specialists outside of pregnancy. They have an ED to recovery program. They are amazing. I mean, and they're greatly expanding, and they want referrals. So let's say you're outside of Dane County, or you have folks that live outside of Dane County. We have a great resource within our department that is awesome. And so I'm going to have Caitlin go to the next slide. Wisconsin Voices for Recovery. And I don't know, Caitlin, if you can click on that link just so we can show them what it is. So this was kind of Alexandra Zagierska's baby, amongst others. Dr. Zagierska was a well-loved member of our department, and unfortunately, her and her partner, Dr. Rabigo, left us, and they're now at Penn State. But if you want to scroll up, Caitlin, so Wisconsin Voices for Recovery is a DFMCH supported program that is a statewide program for advocacy, but also to help identify peer specialists in every single county, hopefully in Wisconsin. It also has great like resources, memberships, and it just really, and we're supported by our department. And Caitlin, if you go to their resource map, Dr. Regner, sorry. It says like, how do you get involved? They have upcoming modules about recovery coaching throughout the state, and they have other resources. The people that run the organization they work for our department. They're in our department. They're our peers, and it's an amazing resource. And again, there's an email at the top of the page if you scroll up all the way. And a phone number, and they're available Monday through Friday, 8 a.m. to 4 p.m. And they can help they know the county-based resources and work with public health and work with CCS programs around the state. And so this is a great resource for people. The other thing is they can text people. So both Safe Communities and Wisconsin Voices for Recovery and peer support specialists can text people, because I think that's the biggest thing too, is like we can, per HIPAA regulations, we can only call patients. We can't securely text them as of yet. And so I think this is an awesome resource, because they, like, peer support people have like found my patients, like, and brought them to clinic like that. And it's amazing, and they're available all the time. It's a tiring job, but it's a really amazing job that they do. And so they just really they do a really good job, and they advocate at the state and national level as well. So I think they're a great resource. And then the other things that I was going to say too is, identifying providers in our department and outside our department. Jacqueline Adams, Dr. Adams from Maternal Fetal Medicine is a great resource. And she and I and Dr. Regner and Dr. Howlett and Dr. Miller and everybody else that's doing this work work very closely together, and they send us a lot of referrals because they want to support family medicine and the care of these patients. The other thing I always like tell people is if people are on buprenorphine or any other medication for their opioid use disorder and you find out they have a positive pregnancy test, please don't tell them to discontinue their medicine. It can be really jarring. They go through withdrawal. There are some studies and some folks in this work that suggest that people do that. I have found that that's not helpful, and patients die. And I really don't like those phone calls. They're really, really hard on all of us and our staff, and yeah. And reach out for assistance. And so I think the next slide then is about I wanted to talk about CPS because I think that's another thing, Child Protective Services. Because I think that kind of ties into the last slide is about the buprenorphine. And so reasons to consider CPS involvement, and every county is different. Serial positive drug screens for things that you don't expect or people don't disclose. They've the initial patient, let's say her drug screen was positive for benzos and cocaine and meth. You technically have to report that. But I always talk to the patient first before I report things. I made the mistake once of not doing that, and it completely damaged my relationship with the patient. But people talk to each other in the community, in that community, in any community, and they're like, we're not going to send people to you. And we want to help people. And so I always let patients know that concern for active substance use and safety concerns or neglect. So that case with our 22-year-old, I would sit down with her, and now your afternoon's blown to pieces. But it is important to take the time to talk to these folks because you don't know when they'll come back. And you want them, and if they know you care about them and you care about their safety and their child's safety, they're more likely to come back to you. And so I always just say, hey, this is what your drug screen shows. If you're able to do point of care, or the next week, let's say they signed up for my chart and you're my charting with them and you're like, when's a good time to talk? And they're like, okay, between this time and this time, I've got minutes, I can do it. And I always just say and when people who are in recovery or have active substance use hear CPS, they freeze. And you may not be able to get to them, but you do have to report it. They may not do anything about it, but I always couch it and tell people I am worried about your safety. I am worried about your infant safety. How can we use this as a resource for you? Not against you, but for you. And it's really important to say that first before you call. Dane County CPS typically doesn't, and I don't want to say one way or another, but Dane County CPS typically one way or the other may not intervene from what I've seen. If you work in outside counties, Jefferson, Columbia, Dodge, they may intervene and they may compel people, and they may take a child away from a parent. And so I think just knowing what your county resources are, and whoever is your assigned social worker at your clinic, because each clinic has we do at least at DeForest. I know Yahara I think does as well, but everybody can do that. And then Allison also put this very helpful comment. It says patients can call 211, and they can get connected to peer support. And I think it's in multiple languages, so that's good. I think just emphasizing other support systems, but also making sure that they have partners in their care. It's not and you should not feel alone either. Reaching out for help. I reach out all the time, to Dr. Miller or Dr. Howlett or Dr. Adams or Dr. Stewart or Dr. Butnagar at New Start. And I'm like, what do I do? I don't know what to do. And they're like, okay, we'll help you think through this and we'll help you figure out resources. And then, but this has all been severely limited in light of COVID and that connection and the ability to like meet people is really difficult. It's hopefully getting better, but the nice thing is trying to like minimize the number of trips that people have to go on, and seeing how many things you can bring into your clinic. And luckily, I mean, we hopefully will be able to expand this to all clinics, but I have a recovery coach in my clinic that works with all my patients. I have an assigned social worker. I have an assigned nurse that works with these patients. And so that's been really instrumental in helping care for these folks. Next slide. So I also wanted to talk about the state statute just because it ties into, and I know we only have 15 minutes, Bill, and I know there's probably going to be questions. Wisconsin State Statute 292 was developed in the 1990s as a way that the state felt they could help make sure people got into treatment. The law says that you can enforce via a court order for pregnant people. It says pregnant women because it's not inclusive language to enter, so they can compel somebody. So this 22-year-old, if they live in a county and their district attorney wanted to do that, they could compel this person to enter a treatment program without their consent and compel them to take methadone and buprenorphine without their consent. And it mandates that we report all pregnant people with any type of substance use disorder, whether it's active or inactive, whether they're on medication, even if they admit to attending treatment programs. It's tricky because like some people report even for past substance use and some people report for current. The punitive damage for this is astronomical, and the reason for this, it's actually colloquially called the, quote, cocaine mom law because of Black and brown people in the early 1990s using crack cocaine. That's the reason for the law. It's inherently racist, but anyways, it has not been overturned. The Supreme Court refused to overturn it probably about 5 years ago. So. Place of advocacy. Okay, postpartum, and then we can take questions.
We'll briefly discuss postpartum care because even if you didn't care for these patients during pregnancy, there's a chance that they may need to establish with a primary care provider after they've delivered. And I think it's important for us then to be aware of some postpartum issues. And I will just mention that I probably will not be able to stick around for questions. I have my first 2 afternoon patients, even though my schedule is blocked, they're here. Woohoo! But I do want to just welcome any follow-up, either emails or calls or anything, especially because I am in Access, which, I have I'm both a DFMCH employee and Access employee, but just want to welcome our collaboration together on these patients. So for postpartum follow-up, it's really important, as Dr. Atluru mentioned, oftentimes she's seeing patients for prenatal care, and then maybe they're going back to see their routine PCP for follow-up. So to be able to coordinate well between, who's going to do the postpartum check and then what's the plan going to be for medications and just other supports after someone delivers. There are a lot of really great supports in both hospitals to help people through that initial postpartum phase. I think it's really important to make sure that we are continuing to support people in their recovery in those first couple of days after hospital discharge. There's a lot of reasons why the postpartum period is a very high risk time for relapse because people aren't sleeping, their life has just changed dramatically, and many of the maybe typical supports or typical things that they would be doing have sort of gone away. And so that's a time that we really need to gather around these patients and make sure that we're following up. And thankfully we do now have this capacity to build more telephone calls into our practice. And so that I think that that's a great way to make sure that patients are feeling support and have what they need by just checking in regularly. So contacting PCP, making sure that follow-up is coordinated. If you are able to care for the child, it's really great to be able to as you're doing weight checks, check in with, you know, parents as well, and just see how they're transitioning. Really make sure you're on, and maybe even being especially proactive about talking about mental health disorders, and bringing up that, really normalizing that that's a common part of the postpartum period, and that medications and seeing counselors and getting extra help is welcomed. Kind of like to use the airplane oxygen mask, you know, visualization with patients, like, you're not going to be able to take care of your baby if you're not taking care of yourself. So how can we care for you to then also care for your family? Making sure you're talking about contraception. And ideally, I like to start those conversations at like 20 weeks, you know, just to give people time to think, and to provide time for, if there is a desire for surgical methods, or if someone wants to have a method placed while they're in the hospital, we can take care of that for them. But just making sure that that's that's part of the conversation, and then helping with any breastfeeding goals that people have. We sort of touched on most of these resources already. The Pregnancy to Recovery. These are some more national resources, but then there are specific UW resources, and there's social work, there's behavioral health, there's counselors in the community that can also help. And doula resources in the Pregnancy to Recovery do continue beyond the prenatal period into that early postpartum period. This, for anyone who's considering doing this care, I think this is an essential piece of information to have around as a resource. It's good to look through just as you're learning about what are the potential medication changes that may be indicated during pregnancy and the postpartum period. How does the physiologic change of pregnancy affect the way that people metabolize opioids, and what can we do to support people in their pain management? So really great resource. And then there are some references here. I feel so bad, I'm going to sign off the call, but I want to just thank you for letting me participate in this. I'm going to let Dr. Atluru share these parting words, and I welcome any comments or feedback after this talk. I would love to just continue this conversation beyond today.
Thank you, Dr. Regner, so much. We understand, and I think all of us are needing probably to get back to things, but thanks for your time and interest in this subject and educating us. All right.
Bill, can I just have 1 minute? There's
of course.
A few questions in the chat, but I just thought I would leave this. This is Don Miguel Ruiz. He's a spiritualist, and I stole it from somebody that sent it out via the addiction medicine listserv at UW. I just thought it was really nice, and to take time for ourselves. Dr. Dalby recommended the personhoodmovie.com. So the state statute that I had mentioned, that statute directly affected this person, and this person was the one that tried to fight it to the Supreme Court and ultimately lost. So that's what I was referencing as well. And then Dr. Dresang does postpartum tubal ligations. I usually send him most of mine, and he does invite you to participate in the care if needed. That's it. Not if needed, if desired.